the exposome at 21. How do we get here, and where are we going? So we're going to step back in time, and we're actually going to go more than 21 years ago. We're going to go back to 2001, where you saw the culmination of another 20 years of effort, both by the government in the Human Genome Project, but also by the private sector with the Craig Ventner completion of the Human Genome Project. And this was the solution to everything in health. We have been told that the genetics are the root cause of all disease. And once we have completed the genome, all the questions will be answered. Well, obviously that's not true. And we knew even then that that was not true. But it really did bring a very different mindset to how we conduct research of the change from focusing on a candidate gene and you're looking at what are the variants in this gene and how is that leading to whatever disease, to thinking about the whole genome and the whole area of genomics coming about. So what were we doing in the environmental health sciences in the early 2000s? Our mindset hadn't really changed that much in the early 2000s. So we were still working under the paradigm from Ricky Pereira and the 1987 National Research Council report on what is the stratagem to get from exposure to disease, going through the internalized dose, what is the biological effective dose, what are the early biological effects, the altered structure function, the clinical disease presentation, and then the ultimate outcome. And then also thinking about points of departure. So if you're in the adverse outcome pathway area, we're still using all of this thinking, but this was the framework that we were operating under. Of you have normal biology and something in the environment perturbs it, and you go down the route towards disease. As the Human Genome Project was being completed, you started to see people, not even in the environmental health sciences. So Walter Willett was publishing, if you look at the four major causes of morbidity, mortality in the United States, cancer, stroke, heart disease, diabetes, very little of that is actually attributable to genetics. This is 2002. This isn't 2026. It's due to environmental factors. Willett was only looking at four exposures: diet and alcohol, smoking, and physical activity. So this is not the NIEHS definition of environment. This is a much broader, more fundamental part of environment. But we didn't really have very strong metrics for any of this. We were using in the. Oh, I need to get closer. Okay. So we were using much coarser techniques to do our environmental assessment. Most of this was based on questionnaire survey data with very low correlation, very low accuracy. Or we were working with the fixed site monitors from EPA and a few mobile monitors. So you were doing a local study and you could take a field deployable monitor out and do the assessment. There were some wearables that were not really wearable. So we had 30-pound backpacks with PM monitors with vacuum pumps and all of this stuff, and we asked kids to go play. And of course, the first thing they did was they took the backpack off, and so you're not actually measuring their exposure, you're measuring something that's close to their exposure. So jumping forward just a few years to 2005 with the firebrand and what I would call a silent revolution. So we all know the landmark paper that Chris Wilde published in 2005, just shy of 21 years ago. So it's the beginning of August, where he was reflecting on the completion of the Genome Project. And we said, in environmental health, we need the same mindset change. We need to think about the exposome. And at its most complete, it's the life course environmental exposures, including lifestyle factors from the prenatal period onwards. But he also was very honest about the challenges that implementing that mindset was going to be. So we have to develop the tools, the capability to be able to do that. That's going to be very difficult to do. And unlike the genome, the environment is not static. It's very highly dynamic. It is, as we just saw with Brad's presentation, it's spatial. It's dynamic in time, in space, and your response to the environment is different throughout the life course. So what were we doing at NIEHS in 2005, and actually a little bit earlier than that? We were not as focused, when I came to NIEHS in 2003, we were not as focused on the exposure side of environmental health. We were very much focused on the biological side of environmental health. And a little known fact is that NIEHS was actually one of the big innovators in omics at NIH. So we did one of the very first genomics projects. We had the Environmental Genome Project, which was looking, it was a candidate gene approach. This started before the completion of the Genome Project in the late 90s, looking primarily in P450s for variants that altered the response to environmental exposures. We had the Toxicogenomics Research Consortium, which was NIH's very first transcriptomics program, trying to develop and understand the variability of transcriptomics technologies and apply that to environmental health sciences. We had NIH's very first proteomics initiative, looking at proteomics approaches to understand the biological response to exposure. And we had the NIH's very first program in metabolomics. And we held the first workshop and published, I believe, the first article that used the term metabolomics was a result of that workshop. We also were the lead on the NIH epigenomics roadmap program. So before the Common Fund, we had the NIH roadmap, and one of the first projects through that was our epigenomics program. And our goal with all of this was to develop the technologies to be able to understand how the biological system, so a systems biology approach, to understand the comprehensive response to environmental exposure. So when I came in, one of my major contributions was we also need to think about how we do the exposure different. Fortunately, we had leadership at NIEHS and NHGRI at the time that was actually pretty keen on really getting into understanding gene-environment interactions. And Francis Collins and David Schwartz managed to make a pitch to Congress that we need a concrete investment to understand gene-environment interaction. But in order to do that, we need to develop the fundamental capabilities first. So we got, I believe, $80 million from Congress specifically to do the NIH Genes, Environment, and Health Initiative. So I got to lead the exposure biology program on this, which was really focused on enhancing the exposure side. And the Genome Institute, under Francis's leadership, so he was the director of NHGRI then, they had the bulk of the money to do genome-wide association studies. So the first GWAS that were published came out of this program, as well as the statistical methodology to do this. The concept of a haplotype map came out of this program. Really, this changed a lot on both sides of the domain. On the exposure biology program, we had a number of different initiatives focused on improving exposure assessment, but not just chemical exposures. So we were focused on chemical exposures, but we were also trying to develop technologies to improve nutritional assessment. So the cell phone pictures that identify what you're eating, how much of it you're eating, those came out of this program. Physical activity assessments, so actigraphs did exist at this time, but something like your Garmin watch, this did not exist. we developed the kernel of those ideas through this program. Psychological stress and use of addictive substances was a focus here. So developing ecological momentary assessment technologies to do contextual prompts. They were looking at stress markers and behavioral cues from wearable sensors, and they would send text messages to do prompts of what's going on in your environment with very short surveys on this. So we also had an idea within this that we not only wanted to improve the exposure assessment, but we wanted to improve the linkage of exposure with biological response. So in the chemical exposures, we had sensors for VOCs, particulates, pesticides. In the nutrition side, we had some alcohol assessment and those things. But we linked this to projects that were using that systems approach to look at biological response and identify early biomarkers of susceptibility in readily accessible biological tissues. So that program was active from 2007 through 2010. And the real focus of the sensor side was developing things that are very usable. They're low, minimally invasive sensors focused on improving, can we measure more things with greater precision and with near real-time spatial resolution, those kinds of things, lightweight, easy to use. We followed that up with a validation program that was really focused on can we do those sensors actually work to measure what we said that they're going to work with ranges that are appropriate to environmental variation? And how do we deploy them? So are they actually usable? Can we put them into a mailer and send them out? So some of the interesting things that we found is if you're doing that, weight actually matters. So one of our PM sensors, the RTI micropalm, was about a 300-gram sensor. But if you could get it less than 250 grams, the cost of mailing went out or went down. So it becomes just a very simple deployment issue of decrease the size a little bit, decrease the weight a little bit, and you save for your study tens of thousands of dollars on postal service expenses, things that you would just not think about as a researcher. So these are some of the technologies that we developed. Most of these are commercially available today, or variants of them. There's been a lot of continued development in this space. But we were also starting to broaden some of the perspective of how do we do the data integration. So how do we take data from questionnaire, from wearable sensors, from the EPA monitoring station? How do we integrate all of that data together? How do we create the maps and doing the correlations like Brad was talking about? So as we were doing that transition from the GEI and the exposure biology program to the validation and starting to think about what are the next steps, I want to give a lot of credit to Steve Rappaport and the real critical insight that he had. So in 2009, he actually read Chris's paper for the first time. And he's like, the way he has described it is like his mind opened, and he's like, this is something that is going to fundamentally change our world if we can do it. So he happened to be on a National Academies panel at the time, and he said, hey, National Academies, why don't we do a workshop on the exposome and have a conversation with the community about, is this something that's real? Is this something that we can do? And as a result of that, he and Martin Smith published the first science article that really laid out how could you implement an exposome project, thinking about the multiple exposure assessments that you could do. The same year was the year that Chirag Patel, as a graduate student working with Atul Boot and this guy named Jay Bhattacharya at Stanford, published his first paper taking NHANES and trying to do a non-targeted analysis, taking all of the analytes that CDC was measuring for NHANES and just saying, what of those correlate with type 2 diabetes with uncontrolled glucose, over 120. And can we discover environmental exposures that are associating with diabetes that we didn't know? And I think there's two important take-homes from that study. One was, yes, you can identify things that you don't know, but you can also identify things that you do know. And I think that that's one of the under-recognized parts of discovery science, is the validation of the approach is you can confirm the known knowns in your discovery science. Because we've been working on these areas for a long time, and we do know a lot. So I'm going to skip over most of the next 15 years in just a few slides to start to think about where are we going from here. So a lot of this has been covered in other venues, and many people already know this, but after that 2010 paper and Chirag's paper, you started to see more and more what I would call comprehensive exposure assessment activities. They weren't really exposome efforts, but they were done with an eye towards building that. So we'll hear from Soji later on GECS and what was happening in Japan. We'll hear from Roll and we'll see what was happening in the Framework 7 and 10. In 2015, we established the Hercules Center, and we also established CHEER, which was the first real exposome effort that we did at NIH. 2016, we established the ECHO Consortium to start to implement Exposome on a tens of thousands of participants scale. And now we're at the era where we've got people that are actually publishing real data on Exposomics, doing the epidemiological studies, and we have these global coordination efforts of NEXUS, IHEN, the Exposome Moonshot Forum that are starting, and GECC, that are starting to pull the community together to think about how do we do this on the scale of a human genome project. And we've seen it happen in the literature as well. So that first publication in 2005, the word exposome does not appear again in PubMed until Stephen and Martin's paper in 2010. There's not a second incidence. Now we're up to we're on course for hitting 1,000 publications this year. So we're really getting there. We've kind of achieved success in building the capacity and implementing the exposome. So where are we going next? Where do I think as a driver, but not a doer, what are some of the things that I think are next? And I want to put a little bit of a disclaimer on this, that these are my own thoughts. When I was putting this together, I was like, I'm going to be very provocative, and I don't know that I actually was as it came together. I think that a lot of this is things that you've already heard from others at this meeting, but these are not the stance of NIH or the U.S. government. With that, I actually think, and this is me, David, speaking, not the director of Extramural at NIEHS. I think we have an unprecedented opportunity right now. We have the MAHA agenda. If you read it outside of a political lens and you put the science first, it is one of the most exciting things that I have seen from the United States government, from an administration. Every line of it is environmental health and the exposome at the forefront. And to back that up, we have, obviously that is a passion of Bobby Kennedy, the Secretary of Health in the United States. But we have Jay Bhattacharya, the NIH director, who is absolutely bought in on the exposome. We have we have strong leadership at NIEHS. Rick got us started, and now I think Kyle is coming in and is driving things in a very positive way. We have an opportunity to deliver and to convince the broader biomedical research community that what we're doing is real, It's important. It's going to give us information on what leads to disease and what can we do to prevent disease and improve health. I nodded to the global coordination, and I think that this is really where the opportunity for us to develop a human exposome project is going to come, because I don't think that a human exposome project can be led by a single country. The Human Genome Project was predominantly led by the United States. It was an international effort, but it was very US-centric. I don't think that an exposome program project can be US-centric. I think it has to be a global effort because the variation in the exposome is too broad. If we really want to understand what is the baseline and what is the normal variation, we have to do it on a global scale. And so having these global coordination efforts where we're bringing people together to think about, what are the technologies, how do we do it, what are the ethical implications of conducting an exposome project, bringing the community together to talk through these issues, and importantly to say, what is the goal? What is completion? So if you step back to the Genome Project, the completion in 2001 was not complete. It wasn't completed until, 2003, they did the T-to-T sequence? So it's more than 20 years after they completed the genome that they actually completed the genome. And so what are we going to define as the point of completion for the project? And then I think that there's also the real public health potential of the exposome and applying that to improved health through precision environmental health and thinking about how do we use the exposome in a data integration paradigm to understand what are the drivers and what are the interventions to improve health at the individual level and at the population level. So what are the policy, what are the behavior changes, what are the activities that we can do to improve health, understanding the individual risk, the individual response, similar to precision medicine, but how does that then lead to improvements in health at the population level? And then I think importantly, how do we integrate the exposome into other omic approaches and thinking about that biological piece of the response and really starting to get at what is the latency, because one of the real key drivers of environmental health is only in a few cases do you have a direct acute relationship between environmental exposure now and disease now. Most of the time there's years or even decades of lag in between where you have a prenatal exposure that is leading to PD in late life. And how do we understand what are the molecular signatures underneath that? So as I'm wrapping up, my thoughts on what are the next steps. We need to maintain momentum. So we need to continue the effort that we have in building the capacity to do the exposomics, the standardization of the technologies. And I think one of the important things is we need to commoditize the exposomic analysis. So when transcriptomics actually became reality is when we got away from doing the kids in the room don't remember, when we used to do transcriptomics, we had inkjet printers in our labs that put little dots of mRNA or oligonucleotides on a microscope slide, and we put those into the Florimeter. Correlation within a lab with a single technician doing it was abysmal, let alone lab-to-lab variation. Where that actually took off was when you had commercially printed arrays that had controls manufacturing, and then ultimately the evolution of that technology into mRNA-seq and those kinds of things. But it was the commoditization that is what actually had it take off, that you didn't have to be an expert. You don't have to be an analytical chemist to do the mass spec. You can just buy a package to do it. And I think particularly in the United States for the next couple of years, demonstration. We need to show take advantage of the opportunity that we have now to show the value of this across biomedical research. We need to continue efforts to build the visibility and nurture those partnerships. So, we've heard a few comments that, you might need 1 million people to do this. How are we going to get cohorts with 1 million people? Well, we're going to build partnerships with the cohorts that already exist. There's things like the Global Alliance for Chronic Disease or the International 100,000 Cohort Consortium that are already thinking about, from the genomic side, how can they do analysis and understand the role of genomics in chronic disease on a global scale. Let's work with those communities to implement an exposome in that as well. And then really start to think about how does the exposome not just inform us about what are the unknown and unknown exposures that are contributing to disease, but what do we do about it? How do we integrate that into clinical practice? One of the things that we've been talking for a few years at NIEHS about is how do we build environmental health, not just the exposome, but environmental health, period, into the relationship of a primary care physician with their patient. You go in for your annual physical, and not only is your phenotype, your blood pressure, heart rate, whatever, being integrated into your course of care, but your exposure is as well. And with that, my timer is done by 10 seconds, and I am done. So thank you all, and I'm happy to take any questions.
Thank you, Dave. That was fantastic. I have a question about what you said about what's the beginning and what's the end of the exposome. Since environment never stops changing, some of the PFAS chemicals we're exposed to today didn't exist 10 years ago. Social media didn't exist 25 years ago. Why do we need to know the beginning and the end?
So I think if we're going to call it a project, a human exposome project, I think part of the billing for that is understanding what the deliverable is at the completion of the project. So I don't think it has to be the original Chris Wilde, totality that gets invoked a lot. But I think we as a community need to say, when have we done enough to understand what is, in my view, the baseline exposome, and what is the normal variation of that, in space? So if I really liked Brad's point about what you're exposed to really does vary very highly by where you live, and that may be contributing to different etiology of disease in those places. So having that map, I think, is really critical.
So as a suggestion, could we define it by life course? We could do a study where we enroll people at all different ages, from pregnancy, birth, and onward till being old like us.
Yeah.
And that's the definition, so that we understand it at each life stage. And then I think we have to acknowledge that we have to always monitor it, because it's going to change.
Yeah, no, some of the conversation that we were having on the boat and over dinner last night is, how do we build the transitive property, if you want to call it that, of, you have early life exposure that's correlated with an epigenetic mark, and then you see in adulthood that epigenetic mark is associated with some preclinical phenotype, which, in a completely different study, you have association of that adult preclinical phenotype with an elderly onset of disease, and you kind of reconstruct the study without having to take a lifetime. That was one of the original complaints of the exposome, is if you're going to do life course epidemiology, those studies are going to take a lifetime to do, and I think it's a solvable problem.
I would just hearken, as a pediatrician, I hearken back to the first growth curves. The way they did it was a time series, so they just measured growth of different children who were at different ages, and they did that in like 2 years. But then they did a longitudinal study that took obviously 20 years, and they did get different results. But the first one got something on the table that was useful, and then the second one, was probably a little bit better, but took a long time.
Yeah, but I think there's a lesson from that as well, that those charts that we use today, I think are the ones that were developed in the 80s. So
Right, and we are, our growth has, it's changed. So it has to be constantly.
it has to be updated regularly. And I think that gets back to your point of the environment is constantly changing. So we're going to have to build into the program the regular updates of what is exposure.
Thank you so much for the great talk. My name is Sarah Assaf. I'm a PhD student in epidemiology from the American University of Beirut. It's very interesting to view the trajectory of how Exposome came to life in US and Europe and other developed countries, and especially since introduction in 2010, and how it has taken on wide research attention and its wonderful findings. But I was thinking, what about the Eastern world and other less developed countries? And I think like expanding Exposome toward these countries should be a priority of the next steps, because people there are vulnerable and have different exposure profile. So what do you think are the challenges in expanding Exposome there, and what's the process of expanding it?
Yeah, I think it's a very important question, and it's actually one that garnered a lot of discussion. So we recently had the Global Exposome Summit meeting outside of Barcelona, and there was a lot of discussion there about how do we integrate the Global South and lower resource countries into this. And I think that point that I was making about the commoditization of the technology. So let the United States and Europe, develop the technology and the capability, because we have the resources to do that. But let us develop it in a way that it's readily deployable by the lower resourced researchers. It's not cost prohibitive to do that. And it's responsive to their needs and interests. So I think that there's an awareness of that within the community. And as we're driving this at NIH, and I know the European Commission is thinking in similar ways, that this is part of the goal, is to have this be usable.